I think we maybe can get started.
Okay, great. So welcome everybody. This is perhaps what will be the first of some webinars that we'll pull together at Emmanuel. And the idea, as with the lecture series, is to find out a little bit more about our parishioners and what they do and in their work and their lives and their commitments. And so we've decided, based on a recommendation of Dodie, of creating a webinar on the perspectives from our parishioners on the COVID-19. And our plan is for each of the panelists, will take about 5 minutes to do a presentation, and we'll have questions afterwards, and then we'll end up around 5 o'clock if we need that much time. But before I introduce the panelists, I'd like Alan just to talk a little bit about the technical aspects of our webinar and how you can get questions to people. Alan?
Thanks, Lee. I want to emphasize that we are all new to this, especially me. There's no one newer. So I've watched the tutorial on webinars about 3 or 4 times, but that doesn't mean that I'm going to be perfect at it. But each panelist you'll be focused on a panelist when they make their presentation, and you have a question and answer space in your screen where you can type a question. And please feel free to do so. I'm going to kind of referee those and direct them to the panelists during a question and answer time. So, and also if you're having any technical difficulty or you're not seeing what you think you should see, please use the question option to let me know that so that I can try to do something about it. So I think we're ready to go unless anybody has any questions at this point that they are concerned about before we get started.
Thanks, Alan. So we're going to ask David Jackson to go first, and Ashley, and then Caitlin. David, as many of you may know, is the adjunct professor of geriatric medicine at Johns Hopkins University School of Medicine. He's the former director of the Ohio Department of Health and member of an Ohio COVID-19 task force headed by 2 former governors of Ohio, Robert Taft and Richard Celeste, to assist the current governor, Michael Devine, and his current health director, Dr. Amy Acton, to secure the increased supply of COVID-19 testing materials necessary to respond to the pandemic. So David, could you share a bit about your experience and your perspective?
Well, sure. To give a little context to why Ohio, Chuck Carpenter was the head of medicine at Baltimore City, and when he left to be chairman at Case Western Reserve in Cleveland, he recruited a small group of young academics to go, and we loaded our Conestoga wagons and went west of the Alleghenies to Cleveland. Somehow I left after 9 years as the director of critical care medicine in the Department of Medicine to become Governor Dick Celeste's health commissioner in his first term. And so that's how I got to know one half of the leadership of the task force, Dr. Dick Celeste. Mike DeWine is a member of the other party from me, but he was smart enough to actually nominate and put in place a very, very strong health director, Dr. Amy Acton, who has been at the leadership in the state health department leaders across the country. And one night, 3 or 4 weeks ago, DeWine heard the story of Larry Hogan's wife getting him extra testing equipment in Korea, and talked to Dr. Atkin, and Mike thought, that going to 2 former governors, one Republican and one Democrat, Bob Taft, who, to nobody's surprise perhaps, was a Republican, and Dick Celeste, who was a Democrat, to set up a task force to try and increase the availability of testing materials, particularly to make the move to decreasing restrictions on interactions in the society and in the economy safer, because you can't make those steps without robust testing, contact tracing, and quarantine. And so the next day after he talked to Celeste and Taft, Governor Celeste's former chief of staff, who's a consultant that does policy consulting in Columbus now, was called back to be chief of staff of this task force. And she called me and said, would you be willing to serve? I said, do bears walk in the woods? And we're off. And the first thing I did is I called the CEO of a pharmaceutical company startup in Florida that I'm on the advisory board. And he's an Indian, Asian American executive who has deep ties in India and politically. So I called him to see if he knew of anybody in the international market who might have some supplies. And lo and behold, he had that morning talked to a friend of his in New Delhi who was an investor in a pharmaceutical company in South Korea that just had been approved by the South Korean government as a supplier of kits, and had increased their capacity by 1 million tests a week, and were looking for places to sell them. They had applied for clearance with the FDA, but had not quite gotten it yet, but expected to get it within a week. So I got the information, the costs, and the timing of the availability, and shared that with the task force. Luckily, the task force combined found US suppliers. There was a company in Cleveland that had 3D printing capacity and used it to make swabs, which is one of the real short supply issues. And it had a lot better control with US suppliers on quality, because there's been a lot of, I was going to say a word that began with C, but poorly constructed test kits have been put out in the market by a lot of countries, and gotten a lot of money for them, and they have not worked. So having an American company gave a lot more control, and that seemed prudent. And Ohio has used those supplies now to begin to unwind some of the restrictions. Since we didn't use the 1 million test kits a week that I had come up with, I called around to colleagues of mine who still who were in public health when I was in public health, and still are active, and let them know that there were a potential 1 million kits a week available for anybody else who wanted to purchase all or part of them. The sort of interesting sidebar is that after my conversation with the pharmaceutical executive, he called me back and said, by the way, we're doing COVID-19 clinical trials in Abu Dhabi and New Delhi, and we'd like to have you work on the design of the clinical trials and monitoring that the hospitals are following the protocols that have been developed. So no good deed goes unpunished, and I'm now involved in the 2 trials, one in Abu Dhabi and one in New Delhi. And I think the opportunity to work with Ms. Allen and the 2 governors did bring a remembrance of how government can work and how it can work across the aisle. And in the 80s, when I was health commissioner, my best friend in Columbus, Ohio, was a Republican state senator who was the chairman of the health committee. And he was a conservative business guy from Springfield, Ohio. And when I hired in 1983 an openly gay health educator to do prevention education on AIDS, when Ohio was still a very low incident state, I got a lot of flack for it. He got a lot of flack for it, but it worked. And he was willing to support that, because back then AIDS diagnosis was a death sentence. There was no treatment. And when I did a program in teenage pregnancy prevention, I put more resources than I thought the literature supported into abstinence education, because it was important to him and his constituents. And we worked together across the aisle on a whole range of issues. And later, maybe we can talk a little bit about what I've learned from trying to do that again in the 2020s.
Thank you, David. Lots of interesting information and certainly some questions, I'm sure. So Ashley, we've asked Ashley because she's doing research at Hopkins on face masks, and I've read about it. It's more complicated than I would have expected. So Ashley is a postdoctoral research associate at the Johns Hopkins Environmental Health and Engineering program at the Johns Hopkins Bloomberg School of Public Health. By the way, I think Michael Bloomberg must be very pleased, not only for his investment in the school, but that Ashley's there doing the work as well. I mean, I think it's quite wonderful that Hopkins and the school is getting the coverage that it's getting. And the Environmental Health and Engineering program is also associated with the Whiting School of Engineering. And Ashley is working with a team at Hopkins on alternative PPE filter materials. So Ashley, can you give us a little peek into what you've been doing and what you've been doing?
Absolutely. Thank you for that really sweet introduction. And that side note about Whiting School of Engineering, we actually just merged with Whiting a few years ago, I think 2 years ago. And it's been a really great collaborative process. And the research I'm doing right now is actually in collaboration with their manufacturing facilities for how we can produce PPE, particularly during a national shortage of the material that goes into it. And so I thought I'd talk a little bit about masks and kind of how they work before I go into why we're doing this particular work. So I'm going to share my screen really quickly. And speaking of Bloomberg being happy with all that publicity, my particular area of research is aerosol science, which I guarantee you most people have never heard of until these past few months. My advisor is also an aerosol scientist and was tickled pink a few weeks ago that she got quoted in an article in People magazine, and that Vogue contacted her for how does one clean a cloth face mask? So not the publicity I think people at Bloomberg are used to getting, but as the times change. So the first thing I think a lot of people are asking right now is, does a mask protect me and how well does it protect? And I think a kind of an image that's really useful to think about the ways in which we can protect ourselves from exposure to COVID-19 is something that the occupational health world has been using for a long time called the hierarchy of controls. And if you look at the image, it basically goes from the most effective ways at the top to the least effective ways at the bottom. And you need a combination of all of these ways to really fully protect yourself from a hazard. And so elimination at the top is exactly what we're all doing right now by having this Zoom meeting from our houses, where if you're not in the same room as somebody with COVID-19, if you're staying away from the exposure entirely, you're not going to be exposed and thus you're not at risk. And so that's kind of the best way to protect yourself. And as you go down through these ways, when you can't eliminate your exposure entirely, because we all can't stay at home for months on end, we have to go to the grocery store, we have to go to the doctors, and at some point this isolation is going to lift a little bit and we're going to be going back to work. And how do you protect yourselves when you can't eliminate the chance that you're going to be in contact with somebody who potentially has this virus? And so you go through engineering controls like ventilation, like the sneeze guards and those walls of plastic that are popping up everywhere. There's an article on BuzzFeed this morning about very surreal dining experiences in the States where they're opening up in-person seating where you've got people with like bubbles dropping down from the ceiling to surround a table. That's an engineering control. All the way down through to the PPE, which is this personal protective equipment, which includes masks and gloves, which means you know you're going to get exposed or you think you're going to get exposed. But unlike these kind of other ways to reduce your chance of getting sick, these ones are a little bit more finicky in that they require them to be used correctly and kind of, in some cases, this will go used by everyone. Masks only work if the mask is effective, which not all are, and if you wear them correctly. And a lot of people aren't doing that. So that's kind of a way to think about that. These masks and gloves and social isolation, they're all pieces to the puzzle, and they really only work best when they work together. And so in looking at kind of what a mask protects people from, you really have to get into a little bit about particles and what size they are. And one of the things that's really cool about the particles that we breathe in and that are in the air is it's one of the few things that spans 6 orders of magnitude of difference in the scale of how big or how small a particle can be. So my advisor, Kirsten Kohler, she actually made this table for publication so that it kind of gives a take-home message of what type of particles you need to be concerned about and what mask types will protect you from those particles, particularly in regards to homemade cloth masks. And so kind of starting at the top, you have these huge particles, and they're tiny still. They're less than a hundredth of an inch. But in the world of particles, they're really big. And these are the ones that you get when somebody is coughing or sneezing. They're wet, they're large, they're kind of heavy, and so they fall out of the air really quickly. And these are the ones that kind of have a large chance of having an infectious, like a SARS-CoV-2 virus particle in them, which is really good that they fall out of the air so quickly. Usually in a few, maybe 2 minutes after a sneeze, they're going to be down on the ground and less of a chance of you getting exposed. Also, homemade masks, that's the type of particle that these homemade masks are built to catch, these really large particles. So when you cough or sneeze on this side of the mask and you protect the people that might be in distance of that cough or that sneeze, or even coming out of just regular breathing and talking. And same thing when you're wearing a mask, you are protected really well from these very large particles. Unfortunately, particles get smaller and they still have a chance of being infectious. These kind of tiny particles around 10 micrometers, which is about 1/10 of the size of these big ones that are going to fall out by gravity. These ones can stay in the air. Again, they're mostly coughing and sneezing, but these ones can stay in the air for about 10 minutes. And so there's a good chance that you're walking through kind of a crowded area and you might come across some of these particles before they settle out and fall down and get on the ground. And so again, that's where masks and social isolation and distancing really come into play in helping reduce exposure. And then you've got really tiny particles. These are about 300 nanometers. So these are less than a 10,000th of an inch across. And these particular particles are the hardest to remove from any type of filter material. And that's why N95s and surgical masks that have the ability to remove this 300 nanometer size particle, which is known as the most penetrating particle size, because it's the hardest of anything. Even the smaller ones are much easier to remove than this particular size. And so homemade masks really aren't effective at stopping these particular particles. They'll help reduce how many you breathe in, but they won't stop them. And then you have, again, super tiny nanoparticles, you might hear them called, and they're pretty easy to stop, but it doesn't matter because they're too small to carry the virus. And so you're really kind of looking at these big particles that masks are somewhat effective at stopping, and these tiny particles that homemade masks are less effective at stopping. And so we could go on, what are these different types of masks and how do they protect you? And you've got this N95 mask, and this mask seals really, really well. And so it fits all the way around you and it forces all the air through this filter material. And these masks have to be fitted professionally by people that are trained to do this using challenge aerosols, because one of the things about it, just when you're breathing in air, the air wants to take the easiest path to where it wants to go, just like us. We're not gonna, to get to DC, we're not gonna fly to New York and then take a train to DC. We're gonna go straight to DC. And so when you're trying to breathe it in, if it can go around the mask where it doesn't quite seal, like around the nose or come in from the chin or the sides, that's where it's going to go and it won't be filtered. But if your mask is completely sealed, then the air is forced through that filter material and you have kind of a lower chance of breathing in any particles. And then, hang on, why is this not letting me go to my next slide? There we go. And then kind of the next best type of mask is a surgical mask. And these masks have much the same type of filter material that the N95s do, that are built to filter out that really tiny particle, those 300 nanometers. And they contain a really special material that's hard to find. Right now it's in short supply in order to do that. However, these don't seal. The N95s seal all the way around. These ones fit tightly to the face, but air can still get in from the sides, from around the nose and the chin. And so they provide good filtration of particles, but not perfect. And then the cloth masks are kind of the next level of protection, which is what most of us are using, because we don't need these really, really high exposure risk masks that the N95s and the surgical masks that a doctor who is working with suspected or known COVID-19 patients needs. And these masks obviously don't seal around the nose and mouth. And so you've got potential kind of areas where things can get in from around there. However, one of the other things to really be concerned with is different types of materials have really different filtration efficiencies. So unlike a surgical mask that can filter out most of these 300 nanometer, these really tiny particles, a homemade cloth mask may not be as effective. It will reduce, it might change, instead of say N95 or a surgical mask will do 95% or maybe 70% of those tiny particles. This one might stop 30 to 50 or even less in some cases. So you're reducing your own exposure but not stopping it. So that's kind of one of the things which doctors and nurses and people that are in much more highly exposed environments need those better masks. And unfortunately, as you can tell from the news, they're all in really short supply. And the reason is, if you look at why these masks work differently, the way they filter out particles. These cloth masks are woven like on a loom. And so you can see in this picture on the left-hand side, they've got these holes that line up. And so the particles can kind of just go right through the little holes. And the tighter you have your weave, the better you have your fit, the more particles you're gonna stop, but you're not gonna get that 95% level of like an N95. And that's because they have this layer called a melt blown layer. And you can see on the right-hand side of that image, instead of all the holes being nicely aligned, they're kind of shifted, crazy tangle. And so they do a better job of filtering out the really little particles. And so all through the news, this PPE shortage, a lot of it is because there's not enough of this melt blown layer, which is that crazy angled layer. And so my research is really looking at how do we come up with novel filter materials that are in a much better supply than this melt blown layer, which is shorthanded because this is the raw materials. Nobody expected to need so much so quickly. And so in conjunction with Whiting School of Engineering, we're using commercially available filter material like felt fibers or different variations of HVAC filters. And I've got a system in my lab right now, which that photo is a mess, apologies. I took it really quickly yesterday while I was doing some testing. But we produce salt particles, which are about 300 nanometers, so that most penetrating. And we can see how many we're measuring or how many we're producing normally. And then we can shift our air line so that we're putting all of those particles through one of the filter materials we want to test and see what level of reduction that we're getting. Are we 10% reduction, or do some of these filter materials allow for us to remove 95% of particles? And once we find a combination of filter materials that allows us to filter out that 95% mark that those N95s do, these are all easily producible. They're woven fibers, which means that they don't rely on this melt blown, hard to find material. The School of Engineering is able to actually vacuum form these N95 masks and have removable filter materials using this tested novel material. And so that was a little roundabout way to go through what we're doing and why these masks, the different types, are so important, and also why it's really important that we all wear masks. And I think I went a little bit over my time. I apologize.
Not to worry. It was most interesting. We'll certainly have lots of questions, Ashley, for you. So next up is Caitlin McFarland. And Caitlin is presently in residency. It's a resident psychiatry at Johns Hopkins Medical School, and beginning this July, she assumes the role of psychiatrist at West Cecil Health Center in Havre de Grace and Conowingo, Maryland. Caitlin, you know, I think now we've been through, what, 3 months, and I think everybody's mental health is one that we're all worried about. And when we first talked about this, we talked about especially our healthcare workers and their mental health. And could you give us a little sense of your perspective on what's happening and how we will be dealing with some of this?
That's right, absolutely. So I think that you made a few comments that I think are really pertinent to what I wanted to talk about. The first being the time piece that, as you point out, we are in 3 months into what is essentially a disaster or a crisis, and there's really no end in sight. There's not really, previous crises that we have experienced as a nation have not necessarily been ongoing in this way. I've often heard at least the national response to COVID-19 compared to the national response to something like 9/11. But 9/11 was an acute event that had a clear endpoint and was a very well-defined event. So that's really important to the implications of COVID-19 on mental health. And the other comment that was particularly pertinent to what I wanted to talk about was the impact of COVID-19 on frontline workers. So research has already been published coming out of China mainly that demonstrates that healthcare workers have elevated risks of anxiety, elevated rates of depression as compared to people who are experiencing the pandemic as sort of the population at large. So we know for a fact that there's a demonstrable effect of COVID-19 on healthcare workers. I wanted to share some slides with you that sort of highlight how we think about the different phases of the crisis, which I think is really important to kind of how we're experiencing the crisis in terms of our psychological well-being. So this slide I'm borrowing from Dr. George Everly, a psychologist at Johns Hopkins who specializes in disaster psychology, and from Dr. Karen Swartz, an expert in mood disorders who gave a grand rounds recently on describing sort of the psychological impact of the COVID crisis, but also how our department was contributing to hospital efforts to respond to it. So in this slide, what you're looking at is a model essentially of how one would expect someone to respond psychologically over time to a disaster. And I think, so you have the time bar across the bottom, and then you have the sort of level of well-being, level of confidence represented on the left. And I think it's important to point out that these stages are applicable on many different levels. So what I mean by that is it's applicable to the public at large. I think there's certainly a sense of collective well-being that we experience as a community. The psychological well-being of individuals, and then smaller communities like, for example, Emmanuel Episcopal Church as a smaller community. So we all experience these phases of disaster together. So looking at this, over time you see here, you know that the disaster is imminent, and you have the actual impact when there's a sharp dip in psychological well-being. And that's usually followed by a kind of drawing together, a sense of optimism. This would, in terms of the 9/11 crisis, this would be when people were sending money to New York, when first line responders were being dispatched to New York, when people were banding together and praying and initially responding to the event, and sort of lavishing a lot of attention on people like firemen and police who were responding to the event. So there's a sense of joining together, of responding to the event together, and you actually see an increase in sort of mood. There's a sense of unity, and not necessarily that the mood is good, but that there's a sense of purpose and that there's a sense of energy that people have. And then that energy eventually dissipates, and you have a gradual decline, usually in how people are responding to the crisis and in mental health. And you really bottom out here at the disillusionment phase. This is when people are getting tired. This is when people's energy has really been depleted by the impact of the event, and keeping up the efforts to be together and be united really start to fall away. And then here you have recovery and reconstruction following the event. So this is the general model for how people psychologically respond to a disaster. The next slide I want to show you is sort of the same idea, but this is a model of how COVID is a little bit different. And this is how that response plays out with COVID. So you can see that the response, the honeymoon period, when people were making videos about, washing your hands for 30 seconds and singing songs, and everyone was putting efforts together to make masks and sending meals to frontline providers and sending first line workers like nurses and doctors to New York. We actually saw an uptick, in community cohesion. But what's different about COVID, about this honeymoon period and the disillusionment period, is it's a lot longer. All of this is a lot more drawn out than an acute event, like something like 9/11. And so the curve, both toward the honeymoon phase and down into disillusionment, is a lot more bumpy. We're experiencing over time more micro events related to COVID, particularly as it spreads out of the larger cities on the East Coast to smaller communities. We're really seeing it happen in waves. And so that means that the disillusionment phase is drawn out. I think there's sort of this marathon effect of getting really sort of fatigued over time, and wondering, when is this going to end? When am I going to be able to reconnect with my family and friends? And I think this is where we are right now. I would say that nationally, this is where we are, is disillusionment. I would say in Maryland, this is probably where we are, and also probably in the hospital as well. People are getting tired. It's been a long 1.5 months now of social distancing, of staying at home. People know loved ones and family members who have lost their jobs, and there really seems like no end in sight. And then finally, I think even more than the time aspect of COVID, I think that the thing that I want to highlight about its impact on mental health is that it's really a disaster of ambiguity. And what I mean by that is that we know that this virus is dangerous. We know that it's had a high mortality toll, that we're starting to top 100,000 deaths in our country and over 350,000 deaths across the globe. And it's going on over a long period of time. And we don't know when it's going to end. And I think that the ambiguity, the uncertainty, the not knowing what's going to happen next, the not knowing whether, you know, how this virus is going to respond to different treatments, the not knowing of whether we're going to have a working vaccine sooner rather than later, the not knowing whether there's going to be another peak of the illness in our community in the fall or in the winter, it really heightens the levels of tension and prolongs that disillusionment phase. And so if you're feeling tired, if you're feeling anxious, if you're feeling scattered, if you're feeling like your memories and your brain is not working that well, there's a really good reason for that. And that is the effect of all these factors combined on our mental health. And so I can answer questions eventually a little bit more about specific aspects of mental health, but I really wanted to sort of emphasize the reason that this is so hard on mental health, and also to normalize the experience you may find yourself having.
Thanks, Caitlin. And we'll circle back with you with some questions. But, like, you know, the fact that we can't be with each other, I think I'd like to hear more of your reflection on that. That we, you know, here we're communicating through a machine, and we're no longer able to communicate as human beings. And what will that mean in the future? But let me get back to David really quickly. Let you capture some time to yourself. David, just back to you and your experience with the group of, especially the bipartisan group that was put together by the Governor DeWine. What did you learn from all that?
Well, I think that I put it into two buckets. One is that things have changed since my youth, and I was an Osler intern at Hopkins in 1968 with the first H1N1 Hong Kong flu epidemic. And I was on the only floor in the hospital that had open medical beds over the New Year's weekend when I was the only intern on a 36-bed unit. And the way we respond in the hospital setting now and the emergency room versus the way when in 1968, the head of the training program, a wonderful physician named Dr. Philip Tumulty, came around to each of the units, and there were 3 interns on each ward, and took the temperature of each intern. And the intern that had the highest fever was sent home. And that was the control mechanism for staph infection. I won on my floor with 104. And they didn't even make, I was afebrile because I was taking very high doses of acetaminophen, and I went back to work 4 days later. And we didn't have the protective equipment. So one of the things I've learned is all of the changes that have impacted on how we as professionals respond to the exigencies of a pandemic. But the more important bucket is what I learned that has survived for 50 years in my experience, and longer than that in the history of this country, which is it is vital that we get back to being able to work for the solution of serious problems in this nation and in this society and in the world, and not be so riven into different camps that we can't talk to each other and we can't work together. The fact that a Republican governor asked a former Republican and Democratic governor to put together a bipartisan team that successfully, not because of me, because the kits I found ended up in other states because the team was able to get US based supplies, but we were able to solve a problem very quickly by coming together, and all the networking and all of the experience of the task force helped the governor develop a program that was safer for the citizens of Ohio and better in terms of a role model for how to move ahead as we figure out, is there a way safely to begin to remove some of the interpersonal restrictions that have developed. And I don't know that we can do that in the current environment, but maybe sometime towards the 11th month of next year, or of this year, excuse me, of this year, we can bring together a coalition that doesn't agree on everything, but can start to work towards solving the serious problems we have.
Let's hope so.
Lee, I'm going to
Yeah, I think if you got some questions, why don't you chime in?
expand the view for the participants, and we do have a couple of questions. This one, I believe, is for Caitlin. Can you speak to what we know about risk-taking in this ambiguity space?
So if I'm hearing your question correctly, I'm wondering about how I imagine the question is about knowing that we don't know what the answers are. How do we know what the right things to do are? And how do we keep our morale up in the setting of that not knowing? I think that it's really important to remind oneself daily of the importance of your contribution as an individual, and that it does in fact matter what you do and what you say into response to what's going on, because I think that particularly when we're isolated, there can be a sense of smallness and a sense of nihilism of like, what does this all mean? Like, it's the numbers for preventing deaths are not as satisfying as seeing yourself put out a fire. And so as we start taking risks, as we start opening up more, I think it's really important to remind oneself of how far you've come already. And to be gentle with yourself. Sometimes doing things like going back to work, going to the grocery store in person, actually seeing someone in person, even while you're still social distancing, is going to feel overwhelming, and there may be a desire to avoid that. And I think it's really important to sit with and acknowledge those emotions, and not try to shove them into the background or, convince oneself that one is being any type of judgment other than this is how you are right now.
Okay, thank you. I think this question is for Ashley. What can I do with my homemade mask to ensure the people I come into contact are safer?
So there's actually a couple of answers to this, depending on so the best way for a homemade mask, if you mean like while you're wearing it, to make it more effective, The tighter fitting it is, the better you're going to be, just because more of the air will be going in both directions through the mask. So if you're able to make sure first, it does cover your nose and mouth. I know a lot of people are lowering it, so it's just over their mouth, so it's a little bit easier to breathe. That doesn't work. Should be covering both the nose and the mouth. And if you're able to get one with a nose band, that does work a little bit better. So the tighter the seal, the better you're going to be protected and the better everyone around you is going to be protected. In terms of once you're using it, how to reuse safely, the absolute best way to clean a cloth mask is to just detergent, soap and water. Throw it in the washing machine. If you're lucky enough to have enough DIY masks to just, have like a little bin for them where one a day or one every time you go out, whatever the case may be, put it in there and then wash them. If you don't have access to laundry facilities or soap and water, especially if you're lucky enough to get your hands on a surgical mask, or if you have like a couple of spare N95s in the garage from an old construction project or something, those ones you obviously can't get wet and you can't clean that way. And also, please, my Lyft driver a few days ago had an N95 on, and I got in the car and he sprayed it with Lysol. Stop doing that. Don't get surgical masks and don't get any N95s wet. That damages that melt blown layer I talked about. That's so critical in the efficacy of the mask. Washing with detergent or liquids is only for homemade cloth masks. But if you can't do that for some reason, either lack of laundry facilities or because it's a mask that doesn't tolerate water, the best way to do this is to cycle through in days. If you can get 3, 4, 5 masks, whatever the case may be, and get brown paper bags and label them Monday, Tuesday, Wednesday, or 1, 2, 3, 4, 5, whatever the case may be, and cycle through. Keep the paper bags in a warm, sunny place. And by the time the virus does degrade environmentally, and the longer you're able to leave in between when you wear the mask the first time and the second time, the better chance you have of that mask being virus-free and not infectious. That's actually what Hopkins is recommending their docs do for reusing N95. And one thing also with both homemade and actual PPE masks, the N95s and the surgical masks, you want to always avoid putting a used mask in plastic bags. You do not want to trap any moisture or condensate from your breath on the mask, be that the N95 or the cloth. It'll keep things growing, produce a better environment for bacterial or other growth. So you always want to keep it in a paper bag, which allows it to breathe and to dry out. And a lot of people actually are, if you are lucky enough to have a backyard or a balcony in Baltimore, not that it's been sunny lately, but allowing them to kind of sit in the sun in their little bag is not a bad way to do it.
Thanks, Ashley. You got a vote of great advice on that one.
Yahoo!
Here's another one for Caitlin. What do you do to support each other right now? What are some warning signs to look for? Have you and your colleagues discussed the effectiveness of online mental health care, if not via video chat or over the phone?
I think Liz got a few questions in there. So I think that we're all probably intuitive about the things that we can do to support one another right now. I think that just because we are physically separate from one another does not mean that we have to be socially separate from one another. I think daily contact via phone, via Zoom, email, text, Facebook, I think they're all ways that maybe are not quite as good, well, definitely not quite as good as the real thing, but they're what we have right now. And I think that it's okay to check in with one another. And I think we say, how are you to one another with an expectation that someone is going to say, fine, I'm good. But I think it's okay to say to one another or friends who you might not have a more honest relationship with, saying, how are you? I want to really know how you're doing. in terms of warning signs, I think that we mentioned I mentioned before the impact of the pandemic on the mental health of frontline workers, but this is also going to be especially hard on the mental health of people who already struggle with depression, anxiety disorders, other mood disorders. Any stress to the system is going to be a stress that may spin one of those illnesses out of control. I think that if you notice someone withdrawing, that you're hearing from them less, that the way that they respond to you is changing. They may be giving you less information or more one-word answers. Or if people you live with, you're noticing changes in their sleep patterns, or they're not eating as well as they used to. These are all signs that we look for as psychiatrists, that someone may be going into some kind of a depressive episode or exacerbation of an anxiety disorder. I think it's okay to ask about those things, because often people may not notice it themselves until they're finally feeling. Those things tend to happen before people actually feel that their mood is low. By the time someone's mood is low, by the time someone is experiencing their mood is low, they're already in the throes of a depression. As to the question of online mental health, I would say that outpatient psychiatry in person has essentially gone away for the time being. We are doing exclusively almost 100% telehealth. So we're still seeing patients in the same volume. We're still seeing them for the same length of time, but it's over video. The nice thing about telehealth for mental health, as opposed to primary care, is that we've been doing this for a while. Telehealth has been around for at least a decade, and we've been fortunate as mental health providers to not be limited anymore by the location of the patient. So if I am going to see someone by telehealth in Nevada, I have to be licensed as a physician, or as a, whatever the discipline of the mental health care worker is, in the state that the patient is in. So the Medicare, CMS, federal regulating bodies have lifted a lot of the restrictions on telehealth and made it more accessible, and made it possible for us to start delivering that telehealth care more quickly. As to the question of, is it as good as, in person? I don't think so. I feel as a physician that I get a lot more information about someone from seeing them in front of me. There are things that we look for, if someone is jiggling their knee, if someone is wringing their hands, if someone has a tremor. Those are not things that I'm going to see over video. That said, there's plenty of research to show that, telemedicine is perfectly adequate, that it's safe, that you can deliver safe, effective mental health care that way. And so similar, I think, to the question of how do we support one another right now, this is what we've got, and we've got to use it, and we can make it effective. One of the things that I'm saying to almost all of my patients right now who are in this kind of disillusionment phase, really struggling, not able to go out and do the things that they want to do, is that I think that eventually we're going to all hit this point where we realize that life is not going to be the way it was before. We're experiencing grief over the loss of a lifestyle we had before. That is gone. The lifestyle that we have when we come out of this pandemic may look similar, to what we had before, but it will be different in some pretty fundamental ways. And right now, we have to experience that grief, I think, before we can start forming those new habits and those new ways of being with one another.
I'd like to add a comment on the ambiguity, which I think is an under-discussed topic, because there are so many dimensions of ambiguity in this whole setting, from the virus and will RNA vaccines work to how many people are going to die. And part of the ambiguity is the models have been so flexible, I think is the kindest word. Mm-hmm. We've gone from 2 million people dying in America to 50,000 to 147,000 down to 131,000. And you have people saying to the public, 100,000 is a huge success. And other people saying what John Donne said, that any man's death diminishes me, for I am a part of mankind. Do not ask for whom the bell tolls, it tolls for thee. And it leaves people in communities across this country wondering, what's really going on? What can I believe? And it really exacerbates both anxiety and ambivalence in ways that are profound, I think.
That's right. That's exactly right.
This is really terrific advice and information to think about and digest. Lee, that's the questions we have so far.
That is the question. Those are the questions. Okay. Let me do this. Let me thank everybody. Caitlin, David, and Ashley, you've made our lives more informed and armed us with information to take the steps forward that I think we all need to do. And I really appreciate that. And Alan, thank you for the technical support. But I'd like to ask Anne Marie to say a few words to close out our webinar, and maybe for all of you to think, both the folks on the panel and the folks that have participated in other activities we might do as part of this. But Anne Marie, could you close this out for us?
Surely I can. And I'm just going to add my thanks as well. I had to jump on late because of another obligation. But what a wonderful piece of it that I heard. So thank you to each of you. And I look forward to going back and listening to the first part that I missed. These questions, although scientific, in very, very much so, and in how does this particular virus work? Those are important things to know. I think what I want to say is, and each of you have touched on this, is that all of these things are happening to human beings, to individuals who are created in the image and likeness of God and whose essence is good. And the challenge of remembering that, what Kate talked about really resonates with me on a theological sense, the challenge of remembering and practicing what we know to be true in a time that is ambiguous, where all things seem to be being brought into question. The importance of holding on to those essential and eternal truths, whether we define that as the God of Abraham or some other higher power. The essence of humanity is good, and the seeming assault on that goodness, on that existence, is trauma. And so I think when we wear our face masks, and when we do our research, and when we reach out to one another, that awareness of going back to recognizing the the goodness of the other. As we say in our baptismal covenant, will you seek and serve Christ in all persons, honoring the dignity of every human being. And that is part of this, that all of this is a human experience. And humanity is loved by God. So in that framework, we all do what we can, but it just, holding on to that essential truth seems to me vital as we move into whatever new life is next, because it will not be the same as we have lived of recent days. So that I think would be mine, other than just my comment, other than just again say thank you to each of our panelists.
Thank you, Anne Marie, and everybody. Please stay well, and please stay in touch.
Take care.
Take care, and all the best. Thank you. Thank you, Ellen.